Okay. Our session is open. Today, this session is a very special session about the GLP-1. We know in recent 2 years, GLP-1 is very, very popular in all of the world. But we know this drug a little. But this morning, we have spent 1 hour, arranged 6 speakers to talk about these drugs. The last year, I know, the tirzepatide, just when this is the king of the drug. It's very, very special contention, this drug. So,
yes.
you introduce our
But
session.
I think that we do have only 4 speakers instead of 6, so we might be, first of all, for the speakers, you can take a little bit more time if you need. If not, we will finish a little bit earlier. So our first speaker, without any further delay, our first speaker is Muriel Cresson. Muriel Cresson. And she's going to speak about body remodeling in GLP-1 era, before, during, and after weight loss. Yes. Please.
Thank you, Raina. Yes, thank you for coming so early, the last day of the Congress. There's not 1 week without a paper about a GLP-1, about the benefits, but not also about side effects. So I have no disclosure for this presentation. And what we have to do, what we have to know. So GLP-1, it's a synthetic analog of GLP-1 receptors. It's an incretin hormone naturally released by the gut after meals, and they bind GLP-1 receptors throughout the body. They have an action on the brain to reduce appetite, about heart, about stomach, liver, pancreas, and also adipose tissue. And what matters for dermatologists? Fast loss, rapid. We have to take care because we can lose from 15 to 22% of body weight. Lean mass falls in a parallel. Skin cannot adapt fast enough. That's a problem for a dermatologist or for aesthetic doctor. So we have laxity deflation. And health with wins are systemic. But the face, body, pays a visible price. So what deflates? So facial anatomy. So you can see here, we have deflates about temporal, about deep medial cheek, about jaws, about chin, but also temporal and about submalar deflation. So the mechanisms, we have temporal hollowing, infraorbital tear through, deep medial cheek, submalar deflation. They have specific compartmental deflation. When we look about the people, we can see what deflates. And then we have what we call Ozempic face, of course. You know all of them. So it's dramatical, but of course, there's a so it's important to see that. But I found recently a new paper about the effect of GLP-1 on the GWAT. GLP-1 receptors are expressed in skin cells, particularly peripheral, and it's just suggesting a direct role in modulating dermal function, not just an indirect effect via fat loss. And it's important to see that we have a crosstalk between the GWAT and the fibroblast. So perhaps you use it for several injectables, and you are used to see that. And we can see that the GLP-1 receptor may enhance collagen type 1 and type 3 synthesis via the MP cyclic pathway and cross-activation of IGF-1R. There's also an anti-inflammatory effect. We have a clinical study showing the reduction of 20% in TNF-alpha with the GLP-1 receptor activation via the NK inhibition. And TNF-alpha is a known driver of collagen degradation and skin aging. adipokines secreted by DWAT regulate the dermal fibrate activity. Their loss with rapid fat loss may impair collagen synthesis. So, this schematic shows the dual and paradoxical action of GLP-1 on the skin. So first, the GLP-1 semaglutide, tirzepatide, reaches the skin via the bloodstream after subcutaneous injection. And the dermis contains its own fat layer. DWAT, with adipocytes expressing GLP-1 receptors, particularly, as I said before, perifollicular. And the D-white adipocytes dialogue continuously with dermal fibroblasts through paracrine signal. So adipokine, adiponectin, interleukin 10, IGF-1, and so on. Maintain the collagen type 1 and type 3. And we have a deflation. So we have a decrease of the D-watt volume. We have a decrease of the local adipokine secretion, so less adiponectin, leptin to fibroblast. Decrease of pro-collagen signals. So it's interesting to see the balance between the two effects. So these numbers here on this dia, so we can see that these three numbers everyone should remember. 15 to 22 mean weight loss with GLP-1. 25% of weight loss is lean mass. And 2/3 regain within a year of stopping. So we have perhaps to think about to adapt the dose or to manage the treatment. And the dosing line, each phase carries its own psychological cost. And this sets up the trade-off slide. Look here, the bad drugs. I find myself, but at what price? What is the gain? So the gain is metabolic health restored, about hemoglobin 1C, lipids, body weight, and of food noise. And if it's what we are addicted about GLP-1, it's the end of food noise. It's a real mental liberation. A body they recognize, so it's a social re-engagement, and self-efficacy rebuilt after years of failed dieting. But what they sacrifice? So it's facial aging compressed into 6-12 months. I look thinner but older. Pervasive fear, what if it comes back? It's difficult. And a new mirror on anxiety, because it's different, but still anxiety. Oops. So 3 phases before. So the risk to stratify each patient. Baseline photos and body, it's important to do that just before to accompany your patient. Prejuvenation with bone collagen, and set expectations early. During the treatment, slow titration in vulnerable patients. Protein, it's important to say to the patients to take proteins and resistance training. Monitor is to scale waist and lean mass, and treat the face and body early. And then after, you wait for, it's necessary to wait for weight stability, so 3 to 6 months, and the sequence volume, height, and quality. The lowest effective maintenance dose, do you continue ejection, or perhaps now you can reduce the dose, of course, but perhaps now you can take the new pills, so you can adapt it, it's very new, and address the fear of a regain. So who is at risk? I show you here a patient selection algorithm. So patient starts GLP-1 therapy. Any red flag? No, you can standard pathway. So baseline photos, as I said, body composition, topical prejuvenation, and reevaluates every 3 months. The red flags, if your patient is more than 45, or in a postmenopausal period. Plan to lose more than 15 to 20 kilos. Photo damage, smoking, it's important also for your skin. And prior weight cycling, so visible facial fat pads. And aesthetic vulnerable pathway, it's active prejuvenation with ABD and biostimulators. You will discuss slower titration with prescriber and monthly aesthetic checking. So Here it's a pre-definition, so bone collagen before the fat is gone. So collagen synthesis takes from 3 to 6 months, starting after marginal loss. Loss is starting late. So we can propose some topicals. Then biostimulators are the monopolar radiofrequency or IFU, and or injections also as PLLA, AK, PRF, polynucleotides. And then proteins, and at this time, we can use EBD, and of course, to adapt the lifestyle. So, pace the loss and prepares for the first mirror shock. So, so you can see here the stress. So, about aesthetically, the target is to lose 0.5 to 0.75% of body weight loss per week. So it's very important. Take your time for you, for your body, for your skin. Reach effective dose, reevaluate every 4 weeks. So as I said just before, pause titration at the first signs of marked facial deflation and protein gain. So see expectation before the first injection. And you preserve, of course, the lean mass. So Ozempic face versus Ozempic body. So the mid-face here, so on the face, the mid-face deflation, jaw, you can see platysmal bonding and cervical laxity. And the early treatment with HA biostimulators, as I said just before. For body, also you adapt on abdomen, on inner arms, on breasts, deflation, buttocks, and décolleté and crepinets. So concurrent lost approach with micro-needling radiofrequency, IFU, AMS for your muscles, and you differ cryolipolysis. So there's a repair sequence. Here it's a decision algorithm. I only create it, so with it's not from publication. So first volume, then tighten, third quality, and necessary surgery. What about maintenance dose and the fear of regain? So it's a real debate, actually. So obesity is a disease, or so overweight is a disease, so you cannot cure completely about that, and we have to take care of that. So it's a disease, it's a chronic disease. Lowest effective dose, as I repeat, is important. Don't stop. It's important to accompany your patient. Weight cycling, worse body composition, and then plan with the prescriptor. Here you can see some pictures about before and during the treatment. Here you will manage your patient with injections, of course, here is an example with PLLA to help your patient. Here's a picture from my colleague Arnaud Lambert in France. You can see the patient before, during. It's dramatic. We need to help them, and how we can restore with only injections. Here it's a man also who loses a lot of weight, and you can see 2 months after 2 sessions of injections, we can really improve. So the emotional journey, what it is. So before, 6 phases: hope, relief, grief, rebuild, fear, and balance. Every phase is an opportunity to validate, treat, or refer. The dermatologist is part of the emotional architecture for obesity care and not a cosmetic afterthought. Thank you.
Thank you very much. Stay with us because we have a lot of questions. Thank you. You can present the next speaker. This is the speaker with the hardest name, so we'll let you do it.
Introduce talent, a very famous dermatologist. It's my pleasure. Name is Pungyara Bong.
Okay,
How?
so good morning, all the esteemed colleagues, ladies and gentlemen. My name is Dr. Prao Pan Bunyaradapan. It's okay, I know it's very difficult.
No, it's impossible, it's not easy.
Yeah, it's impossible, sorry. I'm a dermatologist, and I also have board of preventive medicine, both public health and lifestyle medicine. So today, now we are in the era of using the incretin-based peptide in treating the obesity, and it gives us a meaningful weight loss because it can be more than 20%, which is really close to the surgery. But the real challenge happened when the weight reduction achieved, which is referred to the maintain of the weight, while you preserve muscle, preserve function, and also metabolic health. So in my talk, I will focus on the diet and lifestyle strategies for a long-term treatment. First, let's answer why maintenance matters. Because obesity is a condition. It's not a condition, it's a disease. It's a chronic disease that can be recurrent, it can be relapse. And then in SERMOUNT-4 study, it showed that in the person who stopped using the tirzepatide for around 1 year, the weight regained about 15%. So that's why the maintenance planning should be start early. Start before you start the treatment. Don't wait until it's rebound. And then let's take a glimpse a little bit at what incretin therapy do it to the body. The previous talk have shown us, but I'll recap a little bit. It reduced the weight, but it's not purely the adipose tissue, it's also the muscle mass. And I think choosing the right patient with the right indication is the most important. And BMI is the first screening tool. And be aware that in Asian and in European, the cut point is a little bit different. But you know that the BMI didn't tell anything about body composition. So if you need an accurate cure, you need to find a tool for to evaluate the body composition. You can use whether the DEXA scan, which is a gold standard, or you can use the BIA or the bioelectrical impedance analysis, or BIA. Okay, the SERMOUNT-MAINTAIN study showed that on the person who stay on the treatment can reduce more weight than those who stop the medication. And another study, which is the randomized control trial study of 109 patients, showed that combine the exercise and the liraglutide together is give you the associate with the less rebound weight. Okay, so that's why if you need a long-term maintenance in this group of patients, you need to evaluate all angle of lifestyle, whether it was diet pillar, physical activity pillar, is there any chronic stress, is there sleep quality, any substance use. So the main pillar are the diet and physical activity. And protein, in diet, protein is the key because it can preserve the muscle. And the target is 1.2 to 1.5 gram per kilo per day. But please caution in the elderly patients and the person who have the chronic kidney disease. Please distribute the protein across in every meal. And if you detect that if the patients are tentative to undertake it, you can prescribe the supplement, the protein supplement. But in my practice, I also look for the vitamin and mineral insufficiency too. Okay, so but in practical for the protein, I always ask the patient to have the protein on that first meal because it's tentative that they will undertake. And pair it with the high fiber rich food and also adequate hydration to reduce the constipation. And then when you say to the patients, 1.2 to 1.5 gram per kilo per day, some of them will roll their eyes. So please show the easy to understand the visual amount of protein. Like 1 gram of chicken breast give you 23 grams of protein. Okay, we move to the physical activity pillars. There is a general recommendation of 200 minutes per week of physical activity that it found its help with the weight loss maintenance and cardiometabolic health. And everyone focused, last talk, we focused early resistant training. Because of course it's important, it's help to preserve muscle, but actually the aerobic exercise is also important because it helps with the cardiovascular health, which you know that it was the comorbidity with the obesity. But for me, I prescribe exercise to my patient, 4 exercise: resistance, aerobic, stretching, balancing exercise, because we know that stretching and balancing exercise help to prevent the injury from the exercise. And especially in the person who age more than 65, the WHO recommend to do a balancing training to prevent fall 3 or more days a week. Is any one of you here went to the World Expo in Osaka last year? If you go there on Thai Pavilion, we have the Thai innovative stretching and balance exercise tool we call Go E Lung Sawang, or the Grandpa Swang chair. So if any one of you here are looking for 7-year back home, I think this should be considered. Do you have it at home? Because this one, I took it, the one from my house. Oh, you also have it. It's good, isn't it? Oh, you should consider. Okay, so I'll give you the example of my case. Okay, he was 38 years old. He come to consult for about the weight loss planning. He has a problem about that. During this period of time, like few years, he gained so much weight from, he got like chronic stress from work, from relationship, and then it affect his sleep and affect his health with OSA. He tried himself already, cut off all the factors of stress, he changed his lifestyle, but the weight didn't come down. So he chose to use the dual GLP therapy for 5 months. But during that period, he also strictly with his healthy lifestyle and track his health with the device. Let's see the pictures here. Even he stopped the medication for 6 months, the weight still reduced nicely. Even the BMI number is not that good, you see. But look at the body composition. The percentage fat reduced dramatically. He even gained a little bit more of his muscle. So you can see that body composition, that's matter, not the scale. But in my practice, I also look for other biomarker too, like vitamin, mineral level, hormone panel, inflammatory biomarker. You can see that his biomarker, like inflammatory biomarker, high CRP, reduced dramatically, and his testosterone increased up without testosterone therapy. And he feel more strong. He don't have to use CPAP anymore. So the maintenance framework need to be active. Very easy. First step, you need to monitor the body composition regularly. You can ask patients to do that at home, or you can ask them to come back to your clinic or your setting. And then watch the early regain of the weight. Don't wait until a large rebound. And when you detect that, just take action. Revise all the lifestyle strategy, diet, adherence to the activity, stress, sleep quality, and even consider about retreatment. So this is like the take-home message for me. I think the medication is just only the start point for the weight loss. It's not a finish line. If you need a long-term success, you need to have the lifestyle modification and follow-up. And the goal is not just lowering the weight. It's about to help your patient gain a healthier body composition and a sustained function for a longer health span. And this is my last slide. I'll leave you this, that this treatment is not a magic pill. It's not a magic pen. It's have a side effect. It's have a cost, very pricey one. But in the certain people, in a certain patient, it's a powerful tool because it will help them to lose weight. They gain more confidence to go back and wear their old gym suit, okay? They can rediscover their fullness. They have more energy to go out and exercise and begin a healthier life. Thank you. ขอบคุณค่ะ
Thank you very much. Stay with us. I assume there are a lot of questions. Our next speaker is Dr. Smith Arayaskul, and he's going to speak about the weight loss journey blueprint, multimodal weight care with facial rejuvenation for rapid reducers. So are they lucky, the rapid reducers, or maybe not?
Thank you so much, Marina. Thank you so much for the kind introduction. Of course, at first I would like to mention that I'm so glad to join this session. Finally, I found someone who has got speaking the same language as me because sometimes when I'm talking about this, they're looking me like an alien. So, yes, for a little bit of my background, I have a background in dermatology and also in preventive and lifestyle medicine as Dr. Ik. So yes, this is my passion about weight loss and also the aesthetic. So I will be a little bit more focused about the skin and weight loss and yes, with GLP-1 receptor agonists. When we're losing the weight, there are pros and cons that affect our skin. Of course, that when we're losing weight, it's really related to something that is the main benefit for our skin health: inflammation and insulin resistance. Yes, we all know that this, if it happens, and also we can regulate it to be better, it will be giving a lot of benefit to our skin. What is more solid evidence about this is that in 2 chronic diseases that related to chronic inflammation like psoriasis and hidradenitis suppurativa, there are more and more of the evidence that related to the weight loss, especially the GLP-1 receptor agonist. In psoriasis, there are, I think from my update, is 3 RCT already that combining treatment with the GLP-1 and also weight loss with treatment of psoriasis to be control the severity better. In hidradenitis suppurativa is the level of the case series, but giving a lot of quality of life improvement. It's both control the inflammation by controlling the interleukin 6 and also controlling the proliferation of the cells. But on the other hand, when losing fat, of course, that fat and skin has got a lot of connection. The first model that I would like to emphasize with you is the ECM and adipose tissue interaction. Actually, our skin and our fat cell has got a lot of talk. They have conversation together, as Dr. Cruz has delivered before. What I'm trying to say here is that if you have good quality skin, actually the good quality ECM really sending the signal to have adipogenicity. They have the intensity of the tightness of the fat cells. And of course, if you don't have good skin quality, you can end up to be more severe in the fat loss when we're losing the weight. So this is one of the risk factors. Another aspect is that adipose tissue also has got the exosomes, right? From the adipocyte stem cell, we have something called adipose tissue-derived exosome, or the adiposome, that's sending the signal in many kind of cells in our skin. It's regulated our macrophage to be M2 polarity, that's related to regeneration. It's also directly active on the fibroblasts and also keratinocyte for the cell's proliferation and creating macromolecules such as ECM. And when losing the fat, I would like you to have an idea that fat tissue is not just about adipocyte. Of course, it's the structure that supports it, and it's rich of the collagen, especially the very specific collagen type 6, which is one of the markers when we're looking at the biohistology evaluation about this. So when we're losing it, it's not just about the number, it's not just about the quantity of the fat, but it's also about the structure between it that really giving you different kind of the fat tissue when we're losing weight. So as we mentioned before about Ozempic phase, I would like to focus a little bit more that this is not a medical terms. Ozempic phase is a marketing terms. It's quite a media driven one, and it's not unique. It's not only focused on only Ozempic or Wegovy. It's really all about all kind of weight loss. Even though you do only lifestyle modification, we can also having this problem. And yes, usually it's like this, like Dr. Chris has said before, is related to fat reduction and also skin laxity sign. Usually we focus on the temple, mid-face, showing of the jowl fat, and so the submental. If you want to make it more summarized, I think this review literature is really great. It's just published last month in the Journal of Dermatology Surgery. Yes, this is the review from Dr. Konstantin Frank. For the bone, of course, the weight loss is a very short time, so it's not really directly changing the bone, but losing the soft tissue will really show the bone resorption that we may have before. And yes, they even emphasize with the treatment implication that we may use high G prime filler or some biostimulator directly on the bone surface to help it. But what is the main things that as a priority to change is the superficial fat, layer 2. It was proven already that in this layer is the most significantly losing layer. In superficial fat loss, every 10 kilogram of weight loss, we will lose around 11% of superficial fat. Comparing to deep fat, it's only around 7%. Can you imagine that? It's really thin and it's lost this much. So what I really see in my patient is that their face is separated when they're losing weight. It's not harmonized anymore. And of course, even though deep fat is losing a little bit less, but anyway, it's about supportive. It's about projection of the face and also harmonization of the face. So it's also important, and you also have to detect if the patients have got these problems. So for the conclusion, I think weight loss has got pros and cons. It can reduce the inflammation. It can make some disease better. But on the other hand, losing the volume also can create the sign of aging, combining with skin laxity and quality of the skin. It's like vicious cycle that can going on with the weight loss. What I would like to work more is that when we should do the treatment. I try to review a little bit more about the evidence. This is what I found out now today is really leaning on the bariatric surgery cases because they are extreme weight loss and it has got a lot of facial perception behind it. First of all, when we're starting to lose around 1.3 of the BMI point, we will start to recognize the differences in our face. But when we look at changing that a little bit more at 2.3 in female and 2.5 in male, I think it's about the structural change. You will start to look increased attractiveness. So if you're just starting to lose a few kilos, don't be too much confident. You just look changing, not look better. This is what I'm always telling my patient. But on the other hand, there are more studies that are doing further of the weight loss in bariatric surgery patient. We found some correlation between it. First stop, if they can lose at the from the starting point, it have to be clarified. The starting point of this study is more than 30 kilograms, so it's real obesity patient. When they lose 4.4 points of the BMI, it's the maximum range of the attractiveness. But when they are losing more, especially if they reach the level of losing 7.7 BMI point, it will be the older perception. So I think this kind of things really create the blueprint for me to make me understand a little bit more. And in this review literature, really focus on the higher risk group that if you are male, more than 40, like me, and pre-existing photoaging signs, this will be higher in the risk, and maybe you have to warn them. And also about their goals, that if their starting point is really huge with their weight and their goal is quite big, you have to remind them that this is maybe one of the risk factors. If they're trying to lose with GLP-1, of course, or other medication, or even bariatric surgery, losing faster also riskier for the facial aging. So that's why I always telling you this, telling them before is advice, but telling them after they've got the sign is an excuse. So please remind them a little bit when they are higher in the risk. So what is the strategies behind this? Of course, preserving the lean mass like Dr. Prabhupan has delivered before nicely, support the skin barrier, prevent the nutrient gap, both macro and micronutrient, and yes, set the expectation, warning them about it. Usually, the treatment in non-surgical is related to two big things: volume restoration. You can use filler, you can use biostimulator in each layer that is lacking, and combining with skin tightening. I think this is something that is really direct. But what's important, more important than that, is about timing. I think this is the key here. So what I'm trying to do here, so what we have now, the checkpoint 1.3 losing, I think recognize the differences. 2.3 and 2.5 increase the attractiveness. So starting at 4.4 is the maximum attractiveness of the structural showing. And last point, 7.7, which is significantly aging perception. So from this, I shift to my blueprint. At first, 1.3, step 1, just recognize the difference. I will encourage them to take care something like skincare, skin quality, and encourage them to lose a little bit more, to see more results about the attractiveness if their goal is bigger. For step 2, usually I will detect some pre-existing problems that may have, like skin laxity. Usually I starting to cure the patient at this point to make them ready for further losing if they wish to. For step 3, 4.4, this is the maximum effect of facial structure already. So if they are not showing any jawline or any bony prominent and they wish to have it, this is quite a very good level that we can add additional something as a beautification. And at last, if they are quite a high risk patient, I will warn them during this level, especially if they plan or even reach the 7.7 loss, I will focusing on aging perception. But it's not directly like this. Have you seen this case report just published this month, very soon? 66 years old woman using compounded tersipatide. I have to focus on it. It's compounded, it's not the commercialized one. And she has got the persistent inflammatory nodules after stepping up the medication. What is really make this case report really strong, even published in JAAD, because there are 3 factors that make this very solid. First, the drug start before the nodules happen. Okay. The second thing is, when the case stop the medication, the nodule is better. After that, when they reintroduce the GLP compounded again, the nodules come back. So this is quite showing the very strong relationship between compounded GLP-1 receptor and also the nodule reaction. So it really brings me to change my practice a little bit. Please screen your patient if they are on GLP-1 receptor agonist, going more in the details of what kind of the medication they are having. Please be beware if it's a compounded one, because it's not just about pure GLP-1 receptor agonist. Sometimes it's combination of multiple factors like B12 or something other than that. Okay. Please avoid injection in the high-risk window. Like when they are stepping up the dosage, it's not quite a good idea to do some injectables. Please stable for around 1 month and then starting this. And of course, when you have nodules, please manage it nicely with the hyaluronidase or some of the steroid. After that, in this case, they use isotretinoin orally to cure as an adjunctive treatment. But please avoid injecting more fillers to cover it because the nodule will be bigger. So at the end of my slide, I will have some of the example. Stage 1, starting to losing and recognize the differences. I would ask to not take the picture of the case, okay? You can see that she's starting to look different, but I cannot see that she's more attractive. In this kind of case, it's just more focus on the skin quality and, focusing more on losing that reaching their goals, like this. Another step, the attractive detection. Like this case, you can see that the jawline is much better when they lose around 2 point something. It can increase the attractiveness. In this kind of case, I focus on pre-existing problems, doing some skin tightening together with some of the polynucleotide. On another case that reached the maximum point of attractiveness like this, we can notice that she can increase her look. And yes, combination with some of the volumization and also the calcium hydroxyapatite for enhance her structure can giving even better in the look of a younger, even though she's losing a lot. Also, we can do it in male patient that I also would like to focus on the lower face structure with usually I use calcium hydroxyapatite together with some of the injectable collagen. So at last, I would like to see differentiation in case that quite a lot in last step of it, losing more than 7.7. Unfortunately, in this case, she denied to do all injectables. So yes, I can tight her skin, but anyway, when she lose more than 7 point of BMI, you can see that the attractiveness is better, but anyway, she does look a little bit older. But on the other hand, in this case, actually she lose more than 30 kilos. She's losing a lot from 120 to around 80 something kilos. But anyway, she's doing all the treatments along, starting with the MFUV and also the dual frequency monopolar. She adding some injectables when the dosage of the GLP-1 is stable for 1 month. And what I can notice is that, yes, we can maintain her face beautifully. So yes, this is all of my conclusion. So this is my journey. Now this year, I can reach my I lose 10 kilograms. I'm really passionate about it. So if you have anything to discuss about weight loss, holistic health, please feel free to contact me. I'm more than welcome to talk with you about this. Thank you so much.
Thank you very much. Thank you very much. We are going to have a very interesting discussion at the end. Our next speaker is Dr. Atinuch Donkao. Sorry, you have to kind of to correct me. And we are talking about the managing GLP-1 facial phenotype, a layer rejuvenation approach to volume and laxity restoration. Thank you.
Good morning, everybody. Good morning, everybody. I'm Dr. Atinut Dongkao from Thailand, and today I'm going to talk, focus more on the how to prevent and restoration in the patient with GLP-1 facial phenotype. And I have no financial disclosure with this lecture. These two patients, they share the same profile, like they have weight loss reduction, they have volume loss, and they also have the skin laxity. The previous speaker has already discussed about the GLP-1 selective lipodystrophy, and the fat is lost faster than the body. They will have the temporal hollowing, mid-face depletion, nasolabial deepening, jaw and jawline loss, and also as well as segmental laxity. And from some paper, the first one, they do the research from 30 patients with type 2 diabetes receiving the semaglutide and very low caloric restriction and the combination for 12 weeks. And they show that the total body fat has lost about 9.2%. And the other paper, they do the research in 5 patients that received the semaglutide once weekly. And it showed that the temporal fat pad had lost about 42%, while the buccal fat pad lost about 70%. Once the volume has been lost, we can use HA injection or any biostimulator injection to fill easily. But the laxity, it will be a little bit harder because we need gradually regeneration. So for me, the prevention is the key. Let's begin with the mechanism of the laxity first, because the skin and the fat are not that two separate layers. It shares the same component like for the fat, it has the pericellular collagen, especially type 4 and type 6. So when we talk about the resistant gravity to the compression, deformation, or any resistant, we need this composition combination of the dermis, adipocytes, and pericellular collagen. What happened when we use the GLP-1 or GLP-1RA from the baseline in the patient that has hypertrophic adipocytes, the pericellular will be thickening, so it will be a little bit stiffness, so it can resist to any compression or the gravity. During the treatment of GLP-1RA, the adipocyte will shrink faster, but the pericellular collagen cannot rebuild as the same speed, so it has some mismatch. And when post-weight loss, the pericellular collagen will have the reduction on the strengthening to match with the atrophic adipocyte. That's why the visible laxity happened. And why the face lags faster than the body? Because of these 3 main mechanisms. The first one is that the face fat has especially the Barcode fat pad has shared the same like GLP-1 receptor expression, so it can direct rapid response on that. And the second reason is that the skin-associated adipose tissue is rapidly metabolized and it is very labile. So it appears to have the thin skin and also with the reduction of the estrogen production. And it also has the problem with mechanical loading from the gravity as well. We now will move from mechanism to implication with the prevention. The difference between prevention and restoration is that if we aim for restoration, it means we wait until the collagen has already lost. So we have to use lots and lots of modality, require more treatment session, and it will cost higher. So if we use the prevention method, it means that we start to treat before the collagen has start to lose. So we need, we require less amount of the product, and we can have the harmonize to preserve that collagen throughout the weight loss journey. For me, I use this 5% framework. I refer to the FDA consensus that the weight loss will be significant when the patient uses the semaglutide at about 5% weight loss. And for this one, I will, between 2 to 5% of the body weight loss, I will use the preventive window. From 5 to 10%, I will start the treatment. And if the patient has more than 10%, it will be the restoration 31. I have 5 pillars of the prevention. The first one, we have to define the risks of the patient. And then, as I told you, I aim for prevention. So I aim for the biostimulation to increase the collagen production. And we can use the step 3 for energy-based device to make the skin more tightening and increase the elasticity. And the fourth pillar is very important because we have also need to add any nutrition, vitamin supplement, protein, and enough hydration. And the last one, we have to continue follow-up with them. And this is the clinical pathway. I start with the step 1, with the pillar number 1. And I start to use the pillar number 4 here as well. And if the patient start to have some weight loss about 1 to 2%, I start to make the consultation about if they want to start the prevention treatment or not. Anyway, if patient has more than 5% weight loss, I will start to use the pillar number 2, but more intense in combination with the pillar number 3 and pillar number 4. And for maintenance, I will always appoint my patient once a week or once a month for monitor, check up with the skin elasticity, skin laxity, or any volume loss. And these are the high risks of the patient. If the patient has BMI more than 30, and if they plan to lose more than 50% weight loss, these are the high risk patient. And if patient lost more than 2 kilograms per week, or the age more than 40, with photoaging, these are the high risk patients. So you should consult them about what they are going to happen about the fat loss or the skin laxity. To prevention or pillar number 2, I use the biostimulation injection, mainly on the injection. In the patient that has not that severe laxity, I always start with the maybe non-cross-linked hyaluronic acid, the HCC1, the polynucleotide, or injectable collagen. But if the patient wants more of the stimulation, I shift to CAHA hyperdilution or the polymer one. For the energy-based device, I prefer microneedle radio frequency, the HIFU, maybe the infrared or the plasma. In patients that they want to do they plan to reduce their weight, I won't use a lot of the monopolar radio frequency. And pillar number 4, we have to encourage our patient to have the high protein diet, collagen peptide, omega-3 in combination with vitamin C, and enough hydration with zinc. And we have to do the continued follow-ups with the skin elasticity, any visible hollowing, or any rapid volume loss. So we can plan the treatment during our journey plan. And these are my case sharing. My case number 1, I aim for the prevention. This lady, actually she came for me like once a year for maintenance of the HIFU and monopolar radio frequency. The first one is the picture of her last year in the 2024. And in these early years, she came to me. Actually, she wanted to do the same treatment, but I observed that she had some weight loss, reduction of the fat. So I assessed that she has my facial volume loss, my jaw sagging, because she took the tersipeptide and she lost about 7% in 3 months. So I used the prevention protocol, and this patient, she doesn't want to do too much of the injection, so I used the HCC injection with 5-back technique. And this is my plan for her. I will use the high-intensity focused ultrasound in combination with the injection of the HCC once a month. And I will plan to continue as assessment of the skin elasticity and volume and plan at least that. And this is the result. The first one is the picture on 2024, and the second one, sorry, the date is not correct. It is the picture of her in this year, but on the April. I used the HIFU and HCC and then follow up 4 weeks, do the injection with the HCC again. And the last one is the recently one. She lost about 16% of her weight, but she still look good. Not that much volume loss, and she still have good laxity of the good elasticity of the skin, not that much laxity. And I will move to my case number 2. He is a type male, he is 49 years old. This case I mean on restoration. He lost about 24 kilos in 8 months. In this case, he used tersipeptide once a week with caloric restriction and very high intensity of aerobic exercise. He go for like a trail, like once a week. And he has total facial volume loss with static wrinkle, fine line, and hyperpigmentation from photoaging. And also loss of skin elasticity. So in this case, I prefer, even he had lost a lot of fat, but he has poor skin elasticity. So I did not start with the filler injection. I do the improvement of his skin quality first with the EBD in combination with the injection of non-cross-linked HIA combination with 0.01% calcium hydroxyapatite for 4 visits. And in the 5th visit, I start to do the volume restoration with the pegylated HA filler, and then I do the continuous plan for him to do the EBD once a month, and in combination with injection with linear HA. And this is his journey before and after doing all of my treatment plan. And even though he lost about he lost more than about 30% of his weight, but he still looked not as old as the previous one. And this is my last case, is the restoration and also with the prevention. She is a Thai female in her 47 years old. She lost about 40 kilograms of her weight. At that time, at the first one, because at that time we don't know much about the Ozempic phase. So even though she lost about 20 kilograms, and she came for me for just the toxin and the HIFU, so I did only that treatment for her. Anyway, she still lost some of her weight. So in total, she lost 40 kilograms, so about 35% in 14 months. And this is her at her 75 kilograms. So she looked, okay, she's happy with her weight, but she looked older and sagging. And she has a single type, hollow and descent, upper eyelid droopiness, darken of the mouth corner, loose skin, look angry, pore dilatation, and melasma. Before she started to lose her weight, she said that she always hide behind her friend. She don't want to be in front of the camera. She happy about her weight, but she look old. She still don't want to take a photo. So I start to use the filler. In this case, I want to need the immediate noticeable results, so I start with the injection of the HA filler in combination with the EBD and nonlinear HA. And I also plan to do the skin quality treatment for her with the EBD, with the non-cross-link HIA, and continue as planned to do the treatment for her. And this is the injection of the cross-link HA I did for her. Totally, I used 6 cc of the HA filler, and this is her journey before and after the injection. She lost some of her weight, but she looked much better. Okay, this is the before and the after from the other view. And she still wants to lose her weight, so now her weight is stable about 63 kilograms. She is very happy. Now she lost her weight in her happy weight and her happy face. Her face look much more better from before and after. Here, we can restoration of her face, and we can improve her skin laxity as well. And in my conclusion, the facial rejuvenation is not just only about the beauty. It's about giving the patient confidence, so they are no longer need to hide. And I think that is our real success. Thank you so much.
Thank you so much. Our next speaker is Dr. Lucia Hufontaine. She's going to speak about the physiological mechanism and prescribing guidelines for GLP-1.
Hi, everybody, and it's a pleasure to end this session with GLP-1. So I'm endocrinologist based in Paris. So today I will share with you some insights about the physiology and the guideline in more hormonal view. And also discussing like GLP-1, is it a hype or real revolution? We have been using GLP-1 since 2015 as endocrinologists. And yeah, our patients are still the same. So, you know, there is an overstating maybe of some effects, and we will discuss about it. So first of all, what is GLP-1? GLP-1, and we will talk about the other agonists also. But first of all, it's a hormone. It's a peptidic hormone. It is made by the body inside the belly. So you have certain type of cell, L cell in the epithelium, that are endocrine cells that are producing GLP-1. And the first drugs, liraglutide and semaglutide, have been modified also to stay longer in the organisms. So it's a big shift, you know, because we are changing also the natural molecule of the body. So to understand better the difference in between GLP-1, GIP, and later on glucagon, because it will be on the market soon, I think as the pioneer GLP-1, because GLP-1 will be the foundation of the weight loss by controlling the appetite, the satiety in the stomach, and really having lots of receptor in the body and especially in the brain. For the GIP, it will be more about fat targeting in a small amount, but it will provide like a boosting effect when you're using it at the beginning. For people that are really needing motivation just to lose weight at the beginning, maybe choosing more GLP-1 plus GIP. Knowing also that GLP-1 alone have been more studied in cardiovascular disease. So if you have like background of huge cardiovascular disease, just choose maybe more GLP-1 that has been modified. In the Mounjaro, for example, GLP-1 plus GIP, the GLP-1 is the same as natural GLP-1, okay? So you don't have this amplification of staying longer in the body. And the new one, glucagon, the hope is to also increase the energy expenditure, so to preserve the lean mass. So it will really provide a total effect when you combine GLP-1, GIP, and glucagon. So you will have the effect on the appetite, maybe on the fat, the lipid storage, and also the energy expenditure and the preservation of the lean mass. That is a huge problem right now using GLP-1 or GLP-1 plus GIP. So just one slide on the pathway, because there is such a hype around like promising around longevity field using microdosing of GLP-1. So why are we thinking in that way? Just because the GLP-1 will target certain pathway. For the metabolism pathway, there is this protein Ki pathway that will boost the metabolisms. And for the mitochondrial function, we will have an activation of the Krebs pathway that will really target the energy of the cell. And with the AMPK pathway, protein KG, it will have more effect on cardiovascular systems. And with the AKT pathway, we will have some effect on the regeneration and the tissue repairing mechanisms. So it would be a hope in the future maybe to use these kind of drugs also to target other areas than metabolisms. So as you can see here, GLP-1 receptors are everywhere except in the fat tissue. Okay? So it's really important for how you talk with your patient. How many of you using GLP-1 with their patient? Yeah, quite a lot. Yeah, so it's really important for you to also deliver this message that it's not a molecule to help to target the fat tissue. No, no, no. It will help to monopolize the fat tissue by changing the behavior with food, okay? But there is no drug on the market allowed to target the fat tissue. It has been in the past, it has been creating a lot of disaster, okay? So it's not allowed, okay? So we will really target the behavior with the food. And for sure, we will target the brain, the pancreas, the kidney, the gut, the cardiovascular systems, and also the bones. So really interesting also for kidney failure. It will help. That's what also kidney specialists using GLP-1. And in the brain, also really helpful with some addictive behavior. We know that lots of people using GLP-1 also quit consuming alcohol, so it's really good news. But it's a balance, okay? So if you have people like consuming a lot of alcohol, for me it's a no, because the risk of pancreatitis is so high, okay? So just balance also the benefit and the risk to take action and to advise better your patient. You know, the patient really appreciate when you say no, because they want to trust somebody, because now they can access this drug easily, you know, but they want somebody to just provide a framework, a safe framework. So just 2 slides on the studies, because the main studies, the first studies that has been made with liraglutide, we don't use so much liraglutide nowadays. It's like an injection every day, so it's not so comfortable. So after 1 year, a loss of like nearly 8% of the weight, so it was not that much. So the big change and the real hero that also triggers this societal eagerness nowadays was in 2021 with the STEP 1 trial after more than 1 year, losing nearly 15% of the weight. So here for you to also having a good overview on all the molecules in the weight control. So first generation, we don't talk so much about it right now. Second generation with semaglutide, Wegovy. It's important, I don't know in which country, but for us in France, it's important to make a difference in between Wegovy and Ozempic. Ozempic are for diabetic people, Wegovy for weight loss. Mounjaro for the 3rd generation dual agonist, and 4th generation, we still are waiting for the studies, but the promise is a weight loss around 24-26%, so it could be really huge. And for sure, if it preserves muscle mass, it will be incredible also, because I also have patients that are finally having resistance to insulin under these kind of drugs, just because they are losing muscle mass. And muscle mass also sensitized to insulin. So we have other studies that shown finally quite a deception, because compared to the pharmacological studies, we have like half the effect, like 7% for semaglutide and 12% for tirzepatide. And we also notice an early dropout rate of like more than 50% after 1 year and more than 70% after 2 years. So why? Maybe because of the price, maybe because of the side effect, and maybe also people wondering if they are creating some dependence to a molecule. So really important to have like a really profound discussion with your patient. And also studies made in Paris that noticed 25% of loss of muscle mass. That is huge. So yes, GLP-1 is a promise, but maybe not a magic bullet, not yet a Swiss knife. So the protocols were made by the FAM group in that way. We are discussing with Novo and Lilly, because we also noticed that finally the first doses are the best, like 0.25 for Wegovy and 2.5 for Mounjaro. Finally, the best effect on that doses. So right now, we consider that just use these doses until it won't work, okay? Because the main effect is really to control the behavior with food, the satiety and the appetite. That's all. There is no other effect. If there is no weight loss, there is other problems, and we are going to talk about it, and other speakers also talked about it. Lifestyle is really important, and you don't have to compromise with that. Okay, for me, I don't increase the dose if there is no control about the lifestyle, the sleep, the stress, the activity, really important. And people are aware, and they agree with that. And if you don't have any effect after 20 weeks, like a loss of 5% of the weight, just think about maybe switch of molecules, or just stop. I have also patients losing nothing with GLP-1, you know, so GLP-1 is not the magic bullet. There is a lot of things going on. And, you know, obesity is such a complex topic, you know. If it's only calorie intake, we should know, okay? So it's more complex than that. So for me, GLP-1 is a way, like, not to work alone, but more smartly, like with an ecosystem of helper, and also considering therapy. If there is like an emotional relationship with food, it's really the time to also work on this topic. And for sure, using aesthetic medicine to work on the face skin quality, the body contouring, also to help with skin laxity, and just also measure that during your consultation. But I think you are all aesthetic medical doctors, so it's also your first target. But for me, it's also important to ask those questions for people to make sure that they will be happy with their results. And for sure, to work on muscle preservation. For me, each consultation, do you work out? Which kind of workout? Yeah, I'm working, I do cardio. No, cardio is for the heart, okay? It's in the name, okay? So do resistance training. We want to create muscle. Muscle just will expand also the energy, will use the energy, and will provide confidence for people. So we need exercising, and also for sure optimization in the diet, consuming enough protein is really important. About the risk and side effects, there is a lot, and there is new every day. So for me, I will say that for people, if you notice something new, even if it's not related to a most common side effect, just come to me and ask, and I will see with Novo or Lily if there is a link, because sometimes we have like really strange side effects. But the main one are like digestive issues for sure, but also dizziness, fatigue, exhaustion, and we also notice a lack of motivation, because we can decrease also the amounts of dopamine, so make sure that there is no this side effect, because really important for people also. And gallbladder issues, that if you have any doubt, just make just an abdominal ultrasound before using it, because it can be really tricky if you have some gallbladder issue during the treatment and need some surgery. And just to end quickly about this slide, more complicated, but for you to open also windows of discussion and reflection. We just learned that in biochemistry in second years of, maybe first years of medicines. So when you overactivate a receptor, it can change also the configuration of this receptor, and you can create some attenuation of the effect. And we know that GLP-1 was made to react to pulsation, have a pulsative rhythm, okay? So made by the meal, what you eat. And we are converting this physiological rhythmic pulse into a continuous stimulation. And this leads to an overstimulation of the receptor. So for sure, we have people, and we know that in diabetic people, we have a lack of receptor, we have a lack of GLP-1. Okay, so no risk to increase the doses. But for normal people or just overweight, obese people, we don't really know. So just make sure that you don't increase too much the doses, because after that you can overstimulate and overpass the receptor, and it will lead to some resistance to the effect. And finally, people will have probably a level of GLP-1 lower than before beginning the drugs, and it appeared, and it happened in the past. I have a lot of patients from US, and what I have seen is a food behavior worse than before beginning the molecule. So just make sure that you adapt correctly the doses, because all the protocols were made for different type of people, you know. If you're from US, you don't have the same microbiome and the same digestive systems than European people, okay? So it was made for that, because we are all different. But I have a lot of patients just with the first dosage, and it's perfect, okay? And also for me, really important to decrease step by step the doses. Think like corticotherapy, the same. All about hormones is that way. You want to decrease step by step to also retrain the body to make it by itself, okay? And I have a lot of patients just leaving the molecule without any problems. You don't want to create an attachment to the molecule, really important, you know? People have an attachment to food, you convert into an attachment to a drug. It's not normal. I don't want my patient crying when I'm talking about stopping a molecule. okay? Because people don't cry when you say we are going to leave the chemotherapy, okay? So there is a problem if there is this kind of discussion, okay? So you want to make sure that for them, the results are from them, okay? The GLP-1 is a tool, not the solution. So make sure that you change the lifestyle before beginning the molecule. So then for them in the brain, the change were made by themselves, and the molecule just helped to maintain the effect. Really, really important, this connection. I know it's maybe nothing for you, but for the brain of people, it's everything. So just leaving you with this also beautiful picture in 1942, looking at those people, they're all seen and eating like not really good food. And for me, it's not only the food. There is a lot of thing around the topic of obesity. There is the stress, the quality of the sleep also, and also how the food is ultra-processed. That's changing the microbiome of people. So for sure, for you, just keep in mind, select your patient, have a strong discussion about the side effect and also why you are not going to increase too much the molecules, and follow the guideline. You know, you don't want to carry this responsibility in 10 years about side effect, okay? So just follow the guidelines and it will be okay. So more studies ongoing, and it's really helpful. And we know that GLP-1 have saved a lot of patients with our diabetic population, but they are not superhuman right now, okay? So just, there is a really societal hype around these molecules. We are medical doctors. We are here to provide safety. We are here to learn the science. So just don't hide behind marketing. We are here to make people safe and not people pleased, okay? So thank you so much for your attention.
Thank you very much, Lucia. Our last speaker for the session, and I hope that we will have a little bit of time for questions, is Dr. Gustavo Torres de Souza, and he's going to speak about genetic architecture of obesity and cardiometabolic traits predicts response to GLP-1 receptor agonist. Please.
Hello, everyone. Firstly, thank you, everyone, for being here. And also, mostly, thank you for Dr. Rufontaine, because it was an inspiring talk. And it is going to make half of my way into my presentation. I'm a geneticist, so I'm not a medical doctor. I'm a PhD in genetics, so it means I'm boring. So my stuff is going to be very boring in comparison to what I have heard so far. But it does resonate very closely. So what we have found genetically and mechanistically in terms of response to GLP-1s, side effects of GLP-1s, it does resonate very much to what we have seen in clinics so far. And one of the things that really caught my attention listening to the talk and also obviously seeing the research is that when I tried Ozempic, it didn't work. My relationship to food was very bad. So I just kept eating and having the side effects and eating and didn't lose weight. So this takes us to probably one of the latest publications, not the latest study, but the latest results, which were on tirzepatide. And I've brought the one on tirzepatide because it's pretty much going to be the newest large result, but it does correlate very closely, and it's very similar to the ones we have had for the just GLP-1 agonist. And what catches my attention here is that we have grades of response in patients. So not all patients respond equally. This is very clear. So clinically, we see that very clearly. But are there reasons for this? So whenever there's a difference in response to drugs, whenever there's a difference in phenotype we see in a patient, so what we see physically in a patient, it always catches our attention as geneticists as to why are these patients responding differently. As I've said, most of the ways is done here from the previous speaker talk, but just so we are on the same page, this is the full GLP-1 peptide, and here this is interesting because genetically these peptides, they are very similar, not very similar, but they are encoded very similarly and very closely in the genome. And this also means that they go, oh, I can look at that, sorry. This also means that they go to some similar types of cells and they do some similar types of activities. And that goes most importantly to the relationship between having physically something in the intestines and the production of GLP-1 and then the alterations in the intestinal traffic. This is pretty much what it does. As the previous colleague has just said, it's not going to do anything apart from making patients less prone to eating and therefore losing weight. So why is this important and why then patients do differ so much in this response? There's still in the background here, there's an important talk here to ask you and to ask ourselves. Some patients they look the same, they might have the same body composition, but genetically there are some differences. When there are some differences genetically, there are going to be differences in how molecules bind to the receptor. This is an overall thinking, and this seems to be very straightforward. This is always the first thing that comes to our mind when it goes to response to medication. But that's not all. This is an important, part of it, especially from the finding that we have had. Secondly, still in the background information on GLP-1, this is another, this is a boring table, but this table is a table you all have seen very often in terms of the statistics of side effects. So this also comes from the tirzepatide study, and we see also statistics and also proportions of side effects in the patient. So we have from one side a proportion of patients responding differently, but also a proportion of patients displaying different side effects. Why is this important? Because when we went on, and this was published very recently, not from us, but very recently, when we gather these patients together, and this was a retrospective study done in 27,000 patients who used GLP-1 agonists. What we have seen is that there's one single genetic variant or one single position in the GLP-1 receptor that is responsible for a great deal. So it's around here, p to the 10 to the minus 10. Response to the patients to the GLP-1, and obviously we have a range of other molecules that are not here so much up, so it's very important. So the GLP-1 receptor is very important in the response, but obviously when we look at like above p to the minus p less than 10 to the minus 4, we still see like quite a bit of information. So all of these dots here are genetic information that leads us to seeing there is difference in the response. So we're talking about response here. And what have we done? So we have started a bioinformatics study to find patterns in this that are clinically actionable. And obviously the interest is to test these patients, but now we are in the bioinformatics phase for that. And what we have found is the following. So we have within this, so within what is interesting to predict response, what we have is that we have some levels of information. So we have the incretin, GLP-1, signaling, so this is mostly going to be around the GLP-1 receptor and GIP receptor, genes related to appetite and satiety, so not only in the GLP-1, glucose regulation, body composition, cardiometabolic adaptation, which is essentially cardiometabolic risks, which are related to the response or to the overall response or clinical response to the GLP-1 peptides, and treatment tolerability. So all of those have seen to be, well, obviously related in the endpoint. So the GWAS endpoint was related, but also pharmacogenetic anchors, DNA alteration, so RNA expression alterations, EQ2QTL, drug receptors, and so on. So we have a range of other bioinformatic targets we can use to predict if patients are responding. So we've cleaned up a bit that graphic so that we have found some other genes apart from the very good one, the GIP and the GLP-1 receptors, that also helps us understanding whether patients respond more only to the GLP-1 or if we should consider preemptively changing the molecule to tirzepatide, which is the one we have so far that also targets GIP. So this is the first thing we have seen. So the GLP-1 receptor does play a role in how we gain weight, but also respond to GLP-1 receptor. And at the same time, it's very clear and very likely that also the GIP receptor also will play a role in weight gain, but also weight loss. So what we can do here, and what we expect to do in the very close future, is that we'll be able to predict whether patients need the GIP receptor also to be agonized, to be activated. And also we have a range of other molecules that do display some activity in the response. So not really only the response to the molecule binding to the receptor itself, but also the myriad of things that are around the receptor that lead to response, which is essentially cardiometabolic risk, because we know this improves cardiometabolic effects and so on. And this is for us to finalize just a little bit of how the study was done. So we have started obviously looking at the previous study that was a GWAS, and we have added 35 types of endpoints. So this means that we have looked at more or less 100 GWAS studies. GWAS are genome-wide association studies. And this went for us to looking at 2 billion variants. And this allowed us to screen around here to 200,000 variants, and finally ended looking at 140,000 variants that are related to this. And at the moment, we are looking at around 300 variants that could be used clinically and are clinically validatable. We can clinically validate around 300 variants from this group of targeted variants that really have been related statistically and bioinformatically to the response to GLP-1. So this is a summary for you to see for the future which are the molecules and which are the genes related to each one of the parts of the response to the GLP-1. So obviously we have here on the top the incretin response, so this accounts for the efficacy, but we have a range of other things which goes from tolerability, the cardiovascular alterations, and the body composition. So we have heard here loads about how these patients lose muscle. So it doesn't only happen on the face, also obviously happen in the whole body, and it does have an effect in the cardiometabolic effect. So we have seen the link genetically, so molecularly we have seen the link. So this is this was very clearly presented previously by Dr. Fontaine, but we see the link between the cardiometabolic response and people losing muscle. So we know this happens and we know why, but now we also know that there are some genes that help us linking this. So for us to finalize, I think that my time is done. So here is just a brief conclusion on we see clinical variability, and this clinical variability happens by a myriad of factors. Some of them are psychological factors and the lifestyle factors and the behavior towards food, but also there's a biological network that links these results or these patients' alterations to results. Thank you very much. If you need any information.
Thank you very much.
Thank you.
Thank you. We have a few minutes for questions. Any questions from the audience? I want to ask you both, guys. Is there any difference between cosmetic prevention for young patients on GLP-1s versus elder ones? Because clinically, I think that in younger patients, younger I'm talking about until 35, this is my appreciation, maybe even 40. Actually, they look better, and I do not personally see any deterioration in their looks when they lose weight due to GLP-1s. Is there any limit? I mean, any board on which you say you need to be treated prophylactically versus the younger one that you say you don't need anything from me, go to exercise only?
Yes, this is a very great question. I think a very big challenge between young and old people is first, is about the quality of the skin and also the biofield of their skin. Of course, that in younger patients, they will be low in the risk of showing further of the signs when they are losing weight. Since I have presented that is a correlation between the adipose tissue and the skin quality, I think their risk may be less. But anyway, it didn't mean that they need to kill the prevention protocols, because even though they are young, they will have some of the pre-existing problems. In my case, like Asian people, we are tending to have not much of the bone structure. That sometime when we do evaluation, we can see it right away. If she's losing a little bit of the fat, it will really show something. So I will warn her about that, at least just warn her, and also trying to make some of the improvement. Maybe you can start with some of the EBD to make it tighten or to reduce the seriousness of the problems to occur beforehand that it will happen. But on the older patients, usually I will go a little bit more holistic. It will be more aggressive in my way of the prevention. I think only prevention is many degrees. You can do many things, starting from EBD to injectables or biostimulator, and especially the holistic approach of the lifestyle modification. Even reach to the higher holistic treatment like hormonal therapy or peptide. That will be another level. But
I mean, you presented so nicely the blueprints, actually what needs to be done at a certain level of the weight loss on the GLP-1s. Is it relevant to all the ages? This was my question. Actually, when you assess your patient, did you separate between younger ones? And
I do in everybody. And maybe in the older patient that I would like to focus more is chronologically aging. By the structure, you may lose more of the deep fat. So it will be the additional that we have to focus on also.
And I the general question, so maybe you will answer it. Because when I'm talking about the GLP effect on the dermal white adipocytes, the DWAT plays role in skin quality, skin wound healing, and maybe the hair. So hair we know that are affected by GLP-1s. Is wound healing affected by GLP-1s? Do we see it in practice? Because it's supposed to be, right?
For wound healing.
Wound healing, yeah. But because when I'm talking about DWAT, I'm talking usually about the wound healing.
I think this is quite a complex factors. From my humble opinion, I think it's quite pros and cons in this. Okay, I think on the pro side, GLP-1 itself also have induced the fibroblast, reduction of the inflammation, and also better in the insulin resistance, which will, of course, will help with chronic inflammation and wound healing process. But on the other hand, during the treatment, we are risking for lacking of macronutrients, and also losing weight is also key element that we have to focus on the amino acid deficiency that can happen to
what I mean actually, and I think it's completely okay to say that it was not assessed yet. We are talking about DWAT in the healing process after wound, after skin wounding, right? These cells have a potential to become a myofibroblast and fibroblast and assist in skin healing, right? Whether it's scarring associated or even non-scarring associated. So I just wonder whether anybody actually did some study to assess whether there is a different, more scarring tendency, more visible scars. I don't know, but this is what makes sense. There's a lot of studies discussing the hair issue in patients on GLP-1. So I think this is something that needs to be assessed. Any other questions, please? Okay, thank you very much. I think it was very productive session, multi-facial, because we had actually inputs from different specialists. And see you next year. Thank you so much.